Mohak,
Yes. First of all, I'd like to thank everybody for this great conference. Kudos to everybody, and thanks to JB Pharma for allowing me to give this talk. So my topic is, the situation which we face very, very, very commonly in our routine practice, that is the dry eye post-cataract surgery. So by the definition of the DUS, what is a dry eye? First, we need to understand that. So basically, it's a multifactorial disease of the ocular surface, which is characterized by the loss of the homeostasis of the tear film, which leads to the variety of the ocular symptoms, which I'll be talking about, in which this is the whole cycle, vicious cycle. There is a tear film instability, which leads to the hyperosmolarity, which leads to the ocular surface inflammation, leading to the cell death, and there are other so many neurosensory abnormalities. And if we talk about the prevalence of the dry eye, nowadays every second patient, not one patient, every second patient in my OPD is complaining of the dry eye symptoms. And if we talk about the global, it ranges from the 5 to the 33%, but in a country like India, it is almost 54%. So my talk is what happens post-cataract surgery. So we are firstly mostly operating the old patients. They are already, ocular surface is compromised. In case of the female, they have reached the post-menopausal age. There is hormonal imbalance. They are on so many drugs which are also not helping. So what I have found is almost 87% of the patients, they complain of the dry eye symptoms in the first post-operative week. 35 patients, even at the end of 3 months, and almost 10% they do, into the chronic stage. So what are the symptoms which our patients usually, complain of? That's the blurring, there is burning, there is dryness, gritty sensation, there is a stringy discharge, there are the crusty lid margins, foreign body sensation, and also the other factors like, environmental factors like we are already working into the AC. Nowadays, the digital use, we don't keep our eyes off the mobiles and the computers. These all cause to the vicious cycle. So it is important that we should diagnose which type of the dry eye our patients are suffering, and this is just the broad guideline I'll be presenting. So most important thing is to diagnose them pre-operatively and treat them aggressively. So what you do, this is a very routine thing, even if you don't have the fancy machines, just do the basic Swarmer's test, T-bud test, just have the examination of the eyelid, how are the margins, how are the glands, do the staining with the fluorescein or the lissamine green, and you just have this OSDI question, that's just a simple 12 answer. There are 12 questions being there, and you scale from 0 to 100. You just have to ask the patient. It's very simple. So based on that, you just divide whether the patient is suffering for the aqueous deficiency dry eye or the evaporative, it's a mixed one or the toxic one, neurotopic one. So this is just a broad guideline. In case of the aqueous, what we need to give is the preservative-free eye drops. In many of the times, we are giving the gel on the ointment form, and also the essential fatty acids like omega-3 fatty acids play a huge role. In case of the evaporative, like the Larissa said, the ointment plays a huge role. Oral tetracyclines, there are liposomal sprays and oil, they play a huge role. So let us first understand this mechanism. Okay, how does this dry eye happen? As I told you, there is a tear film instability, which leads to the hyperosmolarity, leads to the cell death, apoptosis, there is a nerve stimulation, it causes inflammation, MMP9 and another, they gets released, they cause the damage, and again cause the tear film instability. So this is a vicious cycle. And all these factors, like there is a pre-existing blepharitis, patients undergoing cataract or LASIK, there are environmental factors like I told, they all are responsible. So now we need something, to arrest these various points where these dry eyes are the causing. So to enhance the lubrication and prolong the retention time on the surface, variety of the viscoenhancing agents are being circulated. The main fundamental is that whenever there is a disruption of the tear film, there is damage to the epithelial cells. So while these epithelial cells are being recovered, there is a still chance that our ocular surface can re-injured more. So we need something which works at the ocular surface and it arrests the core mechanism. So that is where the artificial teardrops come into the picture. So before going into the detail, let us just see how they have evolved. So if you see evolution, the first generation came, they are based on the saline-based isotonic or the hypotonic solution with the BAK like preservatives, which personally I don't recommend. Second, there are improvements like the natural and the synthetic polymers like a methyl cellulose, and the synthetic ones like the polyvinyl alcohol, providine iodine, HP-GOR. And nowadays, the most recent kid in the block is the ones which incorporate the hyaluronic acid and the lipid, and I would say the trehalose as well. So now we have all the options. Polyvinyl alcohol, we have HPMC, we have CMC, we have the PEG-PG, HP-GOR, we have HA, we have the trehalose. So, you get confused now, which one to use when. Even today, still, I'm not able to find out the correct one, which one to use well. But whatever the studies have shown us is that sodium hyaluronidase along with the trehalose, because sodium hyaluronidase has a more retention property because it binds well to the ocular surface, and it also has a wound healing properties. So the main goal, like I said, is to, this is difficult to choose which one is going to work on the which patient because all the patients behave differently. But the main aim or the principal aim of all this artificial teardrop has to be to treat the patient's symptoms so they become comfortable. We have to prevent the system escalation as well. And most importantly, why? Personally, I prefer is to dilute or remove any causative agents which are causing the inflammation because inflammation plays a huge role. So keeping in this mind all these factors and the mechanism of action, composition, viscosity, osmolarity, yeah, we have to go ahead and choose. This is a very beautiful chart which will show how you manage. So you have this dry eye disease. Now you have done all these tests. You see that you have the aqueous deficiency. So there are the demolidants like the cellulose derivatives, gelatin, lipid, polymers, and along with the electrolyte, they play a huge role like sodium chloride, calcium chloride, magnesium chloride. If we have evaporative dry eyes and oral tetracyclines, there are liposomal sprays, oil, cationic emulsions play a huge role. There is an altered tear osmolarity. There are a lot of osmoprotector agents like L-carnitine, erythritol, taurine, most importantly, trehalose. And those who cause the apoptosis and prevent it is the cytoprotective agent like they plays a huge role along with the antioxidants and high molecular weight HA, like we have this now, this is the Rizovati is a combination, anti-inflammatory agents like the steroids come also into the picture, cyclosporin, and high molecular weight CAs and trehalose. So this is the vicious cycle. So, it has to be a step-ladder approach. You cannot pinpoint this is a drop I'm going to use. And nowadays, even the company people are becoming smarter. They are incorporating various ingredients into the one formulation. And this is, again, the beautiful chart. This is the basically TL film, lipid layer, aqueous layer. This is what I have talked about, which agents works at the which level. And you can see there is not a single agent which works on only one. So you have to use the combination of this polytherapy. And you have to make sure that you are using a drop which covers most of those ingredients. So why HA? Because HA is, has been predominantly found into the synovial tissues in eye, in the vitreous, as well as the some amount is there in the aqueous humor and the connective tissue angle of the drainage angle. So why HA? Because, it is already synthesized by the corneal epithelial cells. It has a good wound healing properties. It binds with the water well, which I'll be discussing in the next slide. So they are basically made of the negative charge polysaccharide compounds. As I told you, they play a key role in the cell signaling, in the cell adhesions, the wound repair. So these are the most common functions. The most important ones for the eye are that they increase the tear fruit stability, they increase the T-bud time, they increase the corneal wettability by having the more retention time, they decrease the evaporation rate, decrease the adhesion, decrease the staining, and by thus relieving all those symptoms. So the three most important role, it binds effectively with the water, so it resists the hydration. Next, it promotes epithelial wound healing. And third, because of the more viscoelasticity, retention time is quite good. Now let's talk about each one separately. Why they have the more water holding capacity? Because they have the large molecules of the negatively charged ion on them. So what it does, it basically can hold the 1 gram, can hold almost 6 liters of the water. That is quite huge. So what happens? Because of that, evaporation of the water from the HA is quite low. So the effects are prolonged. So this is the main benefit. Second one, as I told you, how does it help in the wound healing or wound repair? So this is the fibronectin. It's an extracellular matrix protein which stimulates the epithelial cell migration. So whenever this complex is formed, it helps in the wound closure and the faster wound healing. And third and foremost is the viscoelastic properties. So what is tear stress? It is the force between the tears and the ocular surface. So we have these viscous properties of the liquid and the elastic properties of the solid, in which combined we get this viscoelasticity. So what happens whenever we blink? These molecules of the HA, they are aligned with each other. So what happens? They become elastic and the non-viscous. So they are spreading uniformly. Just see like this. That is the most important thing. And what happens between the blink? It forms a tangled meshwork. So the solution becomes less elastic and more viscous. So the retention time is quite good. So you get the advantage of both the things.
No, we need to wind up.
Yeah. I would like to say trehalose. Trehalose, we all know it's a sugar. And how does it help? It helps in retaining the, surviving the organism in absence of the water. It basically osmoprotective agents, prevents the denaturation of the protein and osmoprotector agent. And the three factors which I said is that it rehydrates the tear film, protects against the further irritation, and supports the homeostasis of the tear film. And this is just the summary of how does it work. And nowadays in my routine practice, I'm using this combination of the HA along with the trehalose, that is the Rizovati. This is my first choice of the drug. And what I have found is that they are quite effective in not only reducing the patient's symptoms, but against the tear film stability. And when we compared it with the other patients, when we give only the simple lubricant, they work quite good, even with the existing mild and moderate dry eyes. Thank you very much.
Thank you, Mohak. I think we come to the end of this session, but just to summarize in 3 lines, because 3 speakers, 3 lines. One is that, it's better to use